I want to go ahead and welcome everyone to this evening's webinar. My name is Marika Russell. I'm at Mass Pioneer, and I co-chair the Professional Education Committee for the Endocrine section of the Head and Neck Society with my colleague, Dr. Joe Sharp. And we're really pleased to bring you some new content on these webinars, which we've been doing for some time. They've been really successful, and we're really excited with the offerings that we've had to date. We wanted to switch gears, though, and give you a little bit of something different. So we've moved from how we manage things to really sort of how we do things technically in the operating room. I think we all have developed our own ways and techniques, and it's really kind of nice to think how others might do it, how we might learn from others. And so this is an opportunity to share surgical technique from through the eyes and the hands of the expert panel that you see here. So we're really pleased to bring you this How I Do It Part 1 on parathyroid surgery. We'll have a Part 2 on thyroid surgery in December. So I can go ahead and introduce our wonderful expert panel. We got to the S section of the alphabet and invited everybody with an S name. So we've got our renowned Mike Singer from Henry Ford, who will be moderating the session. Maisie Shindo from OHSU, Dave Shanka and from UVA, and Dave Stewart from University of Cincinnati will be our expert panelists, and they'll each be sharing videos with you as a way to sort of demonstrate the topics that we will be discussing. Next slide. So just by way of introduction, if you're not familiar with AHNS endocrine section already, we are quite a large section of AHNS. There are 1,700 members of AHNS at large and about 600 in the endocrine surgery section. If you are part of AHNS, you should be part of the endocrine section. If you're not and you're interested, give us a holler, let us know. Next slide. And you can claim CME after this webinar. There will be a link sent out, so go ahead and fill it out if you are interested in claiming CME. You'll be looking out for that in your email. Next slide. These are our financial disclosures. And next slide. And so with that, I will turn the microphone over to Michael Singer as moderator, and we look forward to seeing what you all have to say tonight.
So thank you, Marika. I'm just going to see if I can share my screen so we can get started. Please, if someone can just confirm for me that they see this slide.
All good, Mike.
Yes. Okay. So as Marika said, that the idea here is to really try and focus not on diagnosis, workup, evaluations, indications for surgery, but get into some of the details and the nuance of the technical aspect of these operations. We really are lucky that we have with us tonight three expert high volume parathyroid surgeons who probably do a lot of things in the same way and probably do certain things in very different ways. So one of the advantages of having kind of a group like this is to hear different people's perspective. And so while for each of the sections we're going to be touching on or focusing on kind of one of the panelists, probably throughout I'm going to ask the other panelists to chime in. Additionally, if certainly people have questions, you can feel free to add those in the chat, and hopefully we'll pick up on those and be able to respond. So as we go on later in the talks, we're going to be talking about minimally invasive parathyroid surgery. We're going to be talking about a technique that Dr. Shindo really has published a lot on and has championed. And then towards the end, we're going to be speaking about the approach to subtotal parathyroidectomy in the context of, say, foregland hyperplasia. But we're going to start out talking about, I think, one critical anatomical fact that I think everyone who's doing parathyroid surgery has to know about. And it's not just that this anatomical fact is important in terms of preserving the recurrent laryngeal nerve, but really it can be used to facilitate the surgery. And so for that part of our session tonight, we're going to be talking to Dave Stewart. So Dave, this is a drawing borrowed from Greg Randolph's really amazing book, and it illustrates the relationship between the recurrent laryngeal nerve and the parathyroid glands. But maybe you want to just talk about this a little bit and use the diagram to illustrate this point for you.
Sure. Thanks, Michael. I think we all know we can pimp our medical students and junior residents about the embryology of the parathyroid glands. The inferior glands are from the third pharyngeal pouch, and the superior glands from the fourth pharyngeal pouch. And the recurrent nerve coming off the vagus is coming from the fourth cleft. So essentially the relationship of the inferior parathyroid, which I think we think of more of as an anterior parathyroid, will always be ventral or anterior to the plane of the recurrent nerve, and that can be helpful. And then similarly or conversely, the superior parathyroid tends to be more closely associated with the nerve and usually just posterior to it, as shown here in this diagram. And while for a single focused exploration where you know where the adenoma is, you probably don't need to go find the nerve. In a case where you are trying to find all four glands, and particularly if you're missing one, it can be very helpful. And that's what the case that we have a video for hopefully will illustrate.
So, and one additional point that I would just add or ask you to talk a little bit about is that relationship of those glands constant? What I mean is when people talk about a superior gland, they tend to think about, oh, it means it's closer to the patient's head, and the inferior gland is closer to the patient's feet. But if you have a gland, a superior gland that say goes lower down, does it maintain that relationship to that nerve?
Yeah, no, that's why I say I think that the concept is to think of the glands as really more anterior and posterior glands, because an undescended inferior gland or an overdescended inferior gland into the superior mediastinum always will be ventral or anterior to the recurrent laryngeal nerve, whereas the superior parathyroid gland, if it's underdescended, say retropharyngeal, or overdescended into the posterior mediastinum, will always be posterior to that nerve. I have not seen an intravagal superior parathyroid, but I think Dave Shanka has, but that would be the rare case. But yeah, without question, the inferior glands are always anterior to the nerve, even if they are up by the carotid bifurcation or down in the mediastinum.
Okay, so Dave, I want to get to your video that you were kind enough to put together for us. So maybe before I start, do you want to introduce it, or do you want me just to start?
Yeah, just a little bit on the case. So this was a large patient with secondary hyperparathyroidism, end-stage renal disease. His PTH was 1700. He had two large parathyroid glands on the left side, which were identified on preoperative imaging, particularly with the ultrasound. The Sestami, I think maybe it picked up one of the glands, and the right-sided glands we had not seen. He had somewhat of a goiter, and his body habitus, made it a little difficult. We started on the left and found the two left glands right away, and then came over to the right. And I usually go for the superior gland first because it's more consistently localized, even though sometimes it's more of a struggle to get, down deep to it. It can be, you feel like it's a win when you find it. So the video starts with us looking for that, and we see a gland down there, and I assumed that it was the superior gland at the time because, as I said, it'd been a struggle to kind of get down deep enough to find it. Maybe you can cue up the video and I can try to comment as we go along. And so the video, it's a little hard to see the gland right now, but myself and the resident can. So I'm using the nerve stimulator PRAS probe because I think that it's the superior gland, and so the recurrent nerve should be just anterior to it. And while we don't have audio, I can tell you that the audio response on the nerve monitor was, yeah, we were not finding the nerve yet. And so we dissect the gland out a little more. You can see it a little more clearly. It's obviously enlarged. Again, I'm trying to identify that recurrent nerve, and typically I would, be doing so visually as well, but in this case, I'm cheating a little bit with my nerve stimulator, and we aren't getting a positive response. And so we clip the gland, and I think, okay, well, we haven't found the nerve, but I'm pretty sure that's the superior gland. Let's go find the inferior gland. Search for the inferior gland for 30 minutes, could not find it. So then we came back and dissected deeper, and you can see the white linear structure there, the recurrent nerve. And again, you can see some of the twitching from the posterior branch to the esophagus and the inferior thyroid artery coming across there. And just superior to that artery is where the superior parathyroid should be, but it's not. And so once we confirmed that indeed we were missing the superior gland, we explored more superiorly, kind of retropharyngeal, and found the somewhat ectopic missing superior gland. We go ahead and decide this was the smallest one, and we put a clip on it and take half of it, and then took out the other 3 glands. But really the key to the case was understanding which gland we were missing. And if we had continued to search for the inferior down in the anterior mediastinum as an example, we never would have found it. His parathyroid hormone level fell from 1700 to about 70, I think, in the surgery, and had dropped down to 40 maybe post-op day 1, and he did pretty well. He did have to stay for a few days for dialysis and such.
So I think that there's two there's 2 elements kind of with the nerve. One is kind of what you're saying, which is you found a gland, and now you're really trying to figure out, okay, is this a superior gland or an inferior gland? And you use the nerve to kind of determine that for you, to say, okay, you now need to be looking anterior, you need to look posterior. But the other thing that you mentioned, and maybe you can just talk about this a little bit, is where you haven't found a gland and using the nerve to kind of guide you to it. And I don't know if that makes sense to you. Do you ever use the nerve to
Yeah,
kind of
I
help
think
you
that
find missing glands?
I think that the recurrent nerve is often very closely associated with the superior parathyroid, particularly when it's in its orthotopic location. It's usually right there where the nerve tends to make its little turn posteriorly. And so that's a nice technique. I think other relationships that I think about, we mentioned the inferior thyroid artery. It comes posterior to the common carotid, and that tends to be the plane that the recurrent nerve is in. So I think the carotid, that posterior surface, is a good reference plane for where the recurrent nerve is. And then the superior parathyroid should be deep to it. So if you haven't gotten to the carotid, and particularly you're not deep to that posterior aspect, you're probably not deep enough to find the superior parathyroid. The inferior parathyroids, I don't think, are as consistently associated with the nerve, so I don't know that it's as helpful, other than to know you're looking too deep. If you know the nerve's there, you need to be more anterior. And I tend to feel like the innominate and staying anterior to the innominate, as we dissect into the anterior mediastinum, is probably the relationship that I would be looking for. So for the superior parathyroid, I definitely feel like the nerve helps you find it most of the time.
So this is, I just want to show quickly, this is actually a video I had, this is actually though the opposite. So this is actually in a thyroid case where I found a clear inferior parathyroid gland, and that kind of helped guide me to the nerve, which I expected to be kind of deeper than that. And so I'll just play this in the background. But while I'm showing this video, so parathyroid gland, and then nerve is going to be in this area, and of course it's always this easy to find to find the nerve. I'm sure everyone would agree. But I guess one other question I would ask for you, and if either Dave, the other Dave, or Maisie have any comments on it, is do you think about the nerve as it relates to not injuring it differently depending on where the expected abnormal gland is going to be? And so I'm just going to kind of show a quick picture. So this picture on the right, thyroid on the right side, and this was a somewhat overly descended superior gland. But the key element here is seeing that nerve running over it. And here on the other side, now that gland has been removed and you see where it was sitting. I mean, it was distinctly deep to that gland. So when you're approaching these cases, do you say, oh, it's an inferior gland, so therefore I don't have to worry about the nerve? Do you say, oh, it's a superior gland, so now in this case I am going to worry about the nerve? Tell me about thinking about the nerve in terms of avoiding nerve injury.
Yeah, I'll be happy to answer. I was going to let Dave and Maisie comment
Dave,
as well, but
start. Yeah.
I think there's no question that the superior gland, you have to be much more concerned about exactly the relationship you showed, where the nerve can drape right over the top of that parathyroid, particularly as the parathyroid gets larger, just the surface area of the gland is bigger, and it's more likely that the nerve goes right over the top of it. It is not safe to just assume that the nerve is okay for an inferior parathyroid, because it can be somewhat adherent to the undersurface, but it's definitely more at risk on a superior parathyroid. So I would say that most of the time on the inferior glands, we try to identify it, and if we don't see the nerve, we just bluntly dissect, lift it up, and once the blood supply is kind of perpendicular and nearly out of the field, we just bipolar it, and that's it. But on the superior parathyroids, much more likely to formally try to identify the nerve before we do any bipolar or transection of any vascular supply.
Maisie or Dave, do you have any additional kind of thoughts you want to add to this topic?
Yes. So basically, I really use the ultrasound to kind of decide where I think that the relationship where the nerve is going to be to the parathyroid. And a lot of I repeat the ultrasound at the time of the surgery, because when you position the patient, things change a little bit. So if it looks like it's a descended superior parathyroid, and I'm looking at where the tracheoesophageal groove is on the ultrasound, I can predict that that nerve is going to look just like that picture. And so I will then intentionally identify the nerve first. And in fact, in this situation, I would, use a nerve monitor. I don't routinely use a nerve monitor anymore in parathyroid surgery, unless it's a re-op. So I think I use a lot of the imaging study to kind of decide where I think that nerve is going to be, or where the parathyroid is in relation to the nerve, and then decide whether I want to find this nerve or not. The inferior glands are interesting because if you have a person with very thin neck, that nerve is often just as Dave mentioned, on the undersurface of that inferior gland, and you have to be really careful as you're coming around the backside, and not quickly start using cautery on the backside.
Dave Shanka, do you have any other thoughts?
Yeah, I agree completely. The pictures you have up, I had this exact case yesterday with a big superior gland where the nerve was just completely draped over the surface of it. So certainly the superior glands are deep to the nerve, and going to tend to be more closely associated with it. But as Maisie said, inferior glands, you also have to be careful. And certainly as you are lifting an inferior gland up, it can tent a nerve up with it. And so you got to be careful on the backside of inferior glands as well. So you should always be thinking about the nerve.
Yeah,
but if you have a superior gland that's like way up there posterior to your superior pole, and you're kind of like above the joint, I don't even bother looking for the nerve, because I know I'm well above that. So it just kind of anatomically depends on where you are.
And this is not really about atypical pathologies, but that idea of the inferior gland and its kind of adherence to the backside of it, that's particularly true. Like if you're, say, dealing with an atypical adenoma that had that more fibrotic component to it, there are times where you really have to be, you literally can be pulling the nerve up with it if you're not careful. Maisie, I know you mentioned it. I just asked Dave, how about nerve monitoring? Routine, selective? How are you using it? I'll tell you that I use it on every single case that I do now, thyroid or parathyroid. And honestly, I've been doing that since I kind of finished fellowship. But how do you guys use nerve monitoring, if at all, in parathyroid surgery?
I also use it on every case, Michael.
Dave?
Same.
Same.
Yeah, always.
See, I used to until COVID and supply chain problem. And I mean, seriously, then we had to like sit there and think, well, does this patient really need a nerve monitor? I mean, we had just this shortage of the NIM tubes. I mean, remember we went through that time when there was a big problem, and I've just become more selective with parathyroid surgery now.
Yep. I get it. All right. So in the interest of time, we're gonna move on to kind of our next topic, which Maisie's gonna kind of be leading, and we're gonna be talking about specifically this focused lateral approach again that Maisie has really been a champion of and has promoted. We're gonna use this though to kind of just talk more generally about minimally invasive approaches and some of the other elements of it. But I do want to make sure that kind of we talk about this focused lateral approach and what advantages, disadvantages, opportunities it provides. And so Maisie, maybe you could just use this initial slide just to kind of describe to people. I mean, I think it's pretty straightforward and just looking at the pictures, but what this approach allows you to do.
So the lateral approach, I also call it the backdoor approach, it's basically if you're doing the anterior approach, you're kind of like splitting the strap and then peeling it away from the thyroid as depicted in this diagram on the left side of the screen. But the lateral approach, you're coming between the anterior border of the SCM and the lateral aspect of your strap muscles. So you're kind of like coming directly to the posteriorly located parathyroid gland as depicted in this right side of the screen here in the diagram. So that's the difference, is that it's a little more direct. And I think one of the things that I do a lot is under sedation. So this allows me to do a lot of these deep posterior glands under sedation, because you're really not retracting as much because you're just going directly to that deep paratracheal space. So that's kind of in essence diagrammatically how I think about this.
Okay, so sorry, let me see if I can actually advance to the next slide. So this is showing the imaging, and you're gonna please, if you could, just explain to us like a little bit more when this is, like you already said, a little bit more just about when this is useful, what the advantages are potentially, and maybe when it's not a great option to consider.
Sure. So if you look at these diagrams with the ultrasounds, you can see if you were to come the usual standard approach, you would have to just sort of separate the strap from the thyroid, retract the thyroid quite a bit to get down to the deep paratracheal space. As opposed to if you come laterally from between this SCM here, I guess I can't control this arrow.
Yeah, sorry.
So you can probably control that.
Yeah,
right there. And you just separate the SCM from the strap, and you're going to be right there as you get past the carotid artery. So once you get there, then it just bluntly dissects out. So that's where I think I find it useful, where it's sort of sitting behind that mid portion of the thyroid, or even the superior portion of the thyroid, where that thyroid's kind of in the way. And I just want to get down there really quickly. And that's when I tend to use this.
And just tell people a little bit about the incision versus a kind of a more standard midline incision.
So the incision is, I designed the incision based on where the lesion is, at the time of the surgery. And I just sort of shifted a little bit to the side of the lesion. I don't go that laterally over the SCM as described, years ago. I can't remember who first described this approach, but so this way, if you have to convert, by chance to bilateral expiration, you're just kind of extending it a little bit contralaterally into your standard sort of thyroidectomy incision. So it kind of goes from almost the anterior border of the SCM because that's all you want to be able to expose is the anterior border of the SCM to past the midline, a little bit past the midline of the contralateral side.
So I don't certainly routinely perform this approach, but I will say that I use a very similar approach when I'm doing, say, reoperative parathyroid patients, where I do a fair bit of reoperative surgery. Hopefully, you're usually not for my own cases, but I find that this approach in those reoperative cases, this is a very helpful approach because you're avoiding all of that kind of scar tissue
Right.
to help you get kind of more posteriorly. So I think the next slide is your initial video. Sorry, this is the CAT scan?
So this is another situation where you see the adenoma. Actually, it's almost like a bilobed adenoma that's sitting, you know, in the paraesophageal region there. And so you can just come straight between the SCM, just get the thyroid out of the way a little bit from the carotid, and you'll be right there. This is also one where I would look for the nerve, because that's probably going to be either just on the medial aspect of it or just on top of it. You just don't know until we get in there. I think the next slide is the one that okay, so this is the sort of the initial, the skin incision has been made, and we're separating the SCM on the right side. This is the right side approach from the strap muscles there. And typically we just use the bovie. I'm trying to remember, I think this might even be done under sedation. I can't remember off the top of my head, but and so now we're coming along the lateral aspect of the straps there. And often you'll see the ansa hypoglossy right along the strap muscles, and then we'll retract the strap together with the ansa medially, and you can see the jugular vein coming into view just underneath the SCM there, right there. I think the next sequence, here we go. Okay, so then I'll just sort of bluntly dissect off the jugular vein. I like to use the Freer elevator because in the central neck, in an unoperated field, it's easily just sort of separates with the Kittner or Freer. I like the Freer. There's the carotid artery. You can almost see the shadow of the vagus nerve there between the carotid and the jug on the right side, and we'll make sure that that gets protected there. And then you start seeing the thyroid capsule immediately on the left side of the screen there. So then we're going to separate, we're going to come between the carotid artery and the thyroid capsule. Again, using blunt dissection, mostly. We'll start to then come into the paratracheal space. And we know that the nerve should be just deep to the carotid artery. So unfortunately, this video is a little choppy, huh? So as I was saying, you know, I think this is like a deep, there's the nerve. So you can see I started looking for that probably because I was anticipating this adenoma to be just sort of deep to the deep to the nerve. So we'll kind of free up the recurrent laryngeal nerve and get that out of the way, and then start looking for the parathyroid adenoma posterior to this nerve between the carotid artery and the nerve. The one thing I'm actually using here is this scope called the Endobrow, which is a facelift, actually a brow lift device. And it just allows me to work off of the monitor if I wanted to do that, or I can see what the resident's doing. But you can easily do this with a headlight and, you know, surgical loops. But you can see the nerve is just underneath the right, the hemostat. Okay, I think the next one. So once we get that nerve kind of freed up, then you can sort of see the parathyroid adenoma peeking out from underneath, or just posterior and deep to that. And I use mostly, you know, bipolar. And then what we'll do next is just sort of grasp the capsule of the parathyroid gland once we see it, but being careful not to grab the gland itself so that you don't artificially release the parathyroid hormone, you know. And this is probably the polar vessel that's going to the parathyroid adenoma. That normally I would try to tie this or bipolar this, but I thought it was too big, so I put a clip on it. I don't like to put clips in the paratracheal space, just because if you ever have to come back and, you know, look for it on ultrasound, then it's very echogenic. But this one I just elected to put a clip in, which is typically not what I would do. So here we are now. The parathyroid gland is going to get, we're going to grasp that with the some kind of hemostat and just lift it up and then just sort of dissect it out bluntly. There we go. And so sometimes you can actually grasp the little vessel that goes to it that you've already clipped off or tied off or cauterized. And then we'll just use the freer and just bipolar everything else around it, because now you know your nerve is out of the way. You can pretty much move pretty quickly here.
Let me ask Maisie, but I'd be interested in both Dave's perspectives on this as well. You know, in the last certainly decade or two, there's been this general movement away from certainly routine bilateral neck exploration and a significant shift to focused, you know, whatever you want to call it, focused, minimally invasive, directed parathyroidectomy. But then in the last couple of years, I feel like there's maybe been somewhat of a move back, at least among some endocrine surgeons, whether ENT trained or general surgery trained, back the other way towards certainly doing routine or doing bilateral explorations on a much more frequent basis. Tell me in your practices, how is that being divided up? I mean, are you mostly doing focused? Are you mostly doing bilateral neck explorations? Tell me about that.
So I'll start with this. The initial assessment of the patient, you know, I decide whether or not there's any risk of multiglandular disease. So multiglandular disease, you know, may be more common. Obviously, I would do bilateral, at least be prepared to do bilateral in somebody who has a familial hyperparathyroidism, obviously MEN patients. And then the patients who have like not primary, but hypercalciuria, significant hypercalciuria associated with their primary hyperparathyroidism. We're talking 24-hour urine calciums in the range of like 500, 600. I think those patients probably have a little higher risk of multiglandular disease. And there's some study previously about those with normal calcemic primary hyperparathyroidism that you operate on. There's some data to support that maybe they have a higher chance of multiglandular disease. So those are the ones that I at least at the minimum complete a unilateral exploration. So I'll take out the adenoma, even though there's a clear-cut adenoma on my imaging that, you know, I've done. But I will try to go look for the second gland while I'm sitting around waiting for the PTH.
So the ipsilateral normal gland.
Yes. And quite honestly, these descendant superior glands, when you expose it, you're actually going to be looking often at the normal inferior parathyroid right on that posterior capsule. Yeah. It often just sort of pops right out at you.
And you are, if you're not looking at all four glands, I assume the standard is you use intraoperative PTH, correct?
Yes.
Okay. Dave, do you have a different approach at all from what Maisie described in terms of bilateral explorations, focus explorations?
My approach sounds very similar. I mean, I will wait for PTH levels, and so it's you know, I don't routinely look for the normal gland on the same side. So you know, if I'm going to do a focused approach, my goal is to generate as little scar tissue as possible, disrupt as little vasculature as possible, and just see what happens with the PTH levels. But if they don't respond appropriately, then I have a low threshold for looking at all 4 glands.
Dave?
Yeah, I agree. I think that the problem with routine bilateral exploration is you scar the whole thing, and it makes re-ops much harder. So if I agree with Maisie, if there's a preoperative reason to believe that they could have multi-gland disease, then it's warranted. But the vast majority of patients, it's a single adenoma. So sporadic primary hyperpara with well-localized imaging, I think you're better off for the patient to take the adenoma and check the PTH levels. If you don't have the PTH levels, I do think that ipsilateral gland check is a good way to go. That's what we used to do, back before we had the rapid PTH available, and it's still a good test. If you find a second big one, then you're going to need to go explore both sides. I guess I feel like if you do the bilateral exploration and there's any question of whether it's asymmetric hyperplasia or a small adenoma, you better err on over-treating the patient, because if you under-treat them and you scarred them all up, it's going to be much harder. Whereas if it's, sporadic and it looks like a single adenoma, and you end up under-treating them and you have not, done the full exploration, it's a much easier comeback. Obviously, we don't want to over-treat or under-treat, but I do feel like once you commit to the bilateral exploration, I start to feel like I need to be a little bit more aggressive, because I don't want to under-treat them and leave, 3 glands.
The other thing that I'm obligated to mention is, especially with these descended superior parathyroid adenomas, where you're most likely your normal inferior gland is going to be ventral to that nerve and probably sort of stuck on the posterior surface. Don't cut any blood vessels, or don't cauterize any vessels, because you may be cutting off that blood supply to the normal inferior parathyroid. This is really important. So, like this patient, I was pretty sure that, this was pretty close to the superior parathyroid before we committed to cutting that blood supply. But that's one of the reasons why I think these descended superior, I do tend to often just find the inferior gland, because it's like right there.
Yep.
And this way, if the patient has recurrent disease, we know we don't have to come back to that side. It's normal. But at the same time, you want to look for the blood supply.
I think my guess is Marika's on, because there's probably a question in the chat. So I will get to that in a minute. I do think it's obligatory for us just to talk about intraoperative PTH and kind of what algorithm, if you have a standardized algorithm or protocol that you're using, not for the draws, but what are you looking for in terms of drops? Historically, people talked about a 50%, and then it became maybe 50% into the normal range. And now there are people who have moved towards 50% in less than 40. Tell me what you're currently using.
I'll let everybody else speak, but I have my own bias on this.
No, Maisie, please. We want to hear bias. That's the fun part.
So I've been burned a few times, but in any event, it really kind of depends on what you start out with, right? I mean, if you're starting out with a PTH level of like 300, it's going to take a little while for that thing to drop. So my protocol is typically I'll run a PTH starting at about 10 minutes post excision, or 10 minutes from the time I devascularize the adenoma that I'm taking out. And I'll draw another one 5 minutes right after that, because I don't want to sit around another 30 minutes before when that one comes back and I'm sitting there going like, okay, now it's like 80. Am I happy with this or am I not happy with this? Then the next one's going to be back in 5 minutes. So from an efficiency standpoint, that's what I do. And I basically want these things to be in normal range. And I do target for 40 and under, ideally, unless you're starting out with a PTH of, like I said, 400 something. But if that's the case, and if I see the kinetics between the 10-minute and the 15-minute is continuing to drop, then it should be okay. So I might stop at 50. So if you're going from 300 to 50, and the previous, then the next one's like, 45, I'm not going to do anything else on the other side. So that's kind of how I think about these things. It's not like a very clear cut, but I do tend to want this within normal range and ideally 40 or less.
I got it. Trust me, I got it. How about Dave and Dave? What are you guys using?
So if I'm doing a focused exploration, I am real particular about sort of right as I've manipulated the gland, right as I'm about to come across the pedicle, I draw a PTH at basically time 0. And then I do a bunch of PTHs. I go in at 5 minutes, 10 minutes, 15 minutes. And, I really, in these focus explorations, like I mentioned, try to disrupt as little as possible. Don't take down any other blood vessels, as Maisie said, because if you do that, you may artificially affect your PTH levels. But I'm watching for a 50% drop, a continuous decline amongst those 4 PTH values that I get. Sometimes you'll see an initial spike at time 0 because of manipulating the gland. And I do like to see the final one under 40.
Okay, Dave.
Yeah, I'm not the most patient, so I agree 100%. You have to draw one at the time of removal. I think the literature refers to it as pre-removal. I think that's kind of a misnomer. It's really at the time when I say call pathology, I've got my adenoma, because you will see some spikes sometime, and if you fail to see that, then you might falsely conclude that you didn't fix them when you did. And then I draw one 5 and 10 minutes. I like to see it 50% drop and continuing to drop between the 5 and the 10. The plateau is where the problem is. And 40 is nice. Below 40, I agree. But if you start higher, I'm just not convinced that you need to wait that long. I mean, you're going to have to just draw more PTHs. So I'm not that strict about it. The way I look at it, it's sensitivity and specificity. And so the stricter you are, the more likely you unnecessarily explore bilaterally. And that's just your personality. That should be maybe a discussion with the patient even. And the looser you are, the more likely you're going to undertreat. So it's a balancing act. But I do think that if it plateaus above, it's in the normal range, but it's above 40 and it didn't continue to drop, that's a worrisome sign.
The other challenge is the normal hormonal variant patients.
Yeah, I mean, what do you do
right?
with that?
I mean, you're starting with a PTH of 50.
40.
So
Yeah.
I'll tell you that I just submitted a paper that I believe is going to be published soon on those patients, and what we found is similar to the classical patients, they have on average a percentage drop of about 80%. So even if the baseline starts in the normal range, you still expect to see about an 80% change, at least in my series. What I do think it's fascinating, we have to move on because of time, but I do think it's fascinating how this PTH protocol has evolved. And I think as time has gone along, we've gotten probably stricter, but I think there's also more of a recognition that there's not one absolute protocol that everyone should be using on every single case, and that there requires some degree of flexibility, certainly from patient to patient. Marika, I promise I'm going to get to you in just one more second, but I have to ask Dave Stewart a question. You said, Dave, that you took out the adenoma and you send it for a frozen section. Do you always do that?
Yeah, I like it. I'm not saying you have to. It's faster.
No, I didn't say you said you have to.
Yeah.
I'm just asking if you do.
It's faster than my PTH machine. So if it turns out I took out a lymph node or a thyroid nodule, I find out faster than waiting for the PTH levels. And then
Okay.
I honestly like to go look at it with the pathologist and see, does it look completely cellular with a rim and normal, particularly those small adenomas, or does it look more fatty? And then, I have them weigh them. So is it 100 or 200 milligrams? I mean, you can kind of get a gross idea looking at them, but the weight gives you an idea. Those small suspected adenomas are where I really think you have to be careful to make sure the PTH goes down. And, I don't know whether it's right to go check the ipsilateral gland. If you check the ipsilateral gland before you've drawn your PTHs, you risk, messing up the kinetics, as Dave Shanka mentioned. So, you could draw them, and then while you're waiting, go look and see is another option. And I thought about bringing a case here where I had a 45, I think 50 milligram parathyroid that had about a 20 milligram adenoma on it, what I'd call like a little microadenoma. You know, those cases are the ones that are, I think, particularly helpful to kind of see that histology and
Yep.
know, yeah, that looks like an adenoma.
We're going to move on because I want to make sure we get to our last case with some time. But Marika, what was the question that you wanted to raise from the chat?
Yeah, so there are a few questions in the chat, but maybe again, in the interest of time, we'll just focus on one or two of these. And perhaps the first question relating to Dave's comment about pathology, Caitlin Fraser is asking about your thoughts on biopsy or marking of normal glands during bilateral exploration. So maybe one or two of you can comment on your thoughts on that.
So I feel obligated to actually make a comment because my mentor, Dave Terrace, this is like one of his kind of favorite topics. He talks about how now he routinely, whenever he finds something that he thinks is a parathyroid gland, he does a little biopsy. I'm sorry to speak for him. I hope I'm not misspeaking. He takes a little biopsy and marks it. And the idea being that essentially you always want to know what you're dealing with. And as Dave Stewart said, no matter how good you think you are at this, sometimes we're wrong. And the problem is if you say haven't cured the patient and all you are able to say is, oh, I think I saw the inferior gland, but you don't have pathological proof of it, it really becomes very difficult to know whether that's a reliable piece of information. So I know he routinely does that. I'll tell you that I don't always do it. If, say, for example, I found a clear adenoma, I see an inferior gland that looks totally normal, I'm checking for PTH levels, I don't always do it, but influenced by my mentor, I certainly am biopsying and marking things more than I used to in the past. Was there another question, Marika?
We want to answer Russ's question.
Yeah, dude, Mizi. So Russ asked the question. So you described earlier your approach to selecting patients for a focused exploration. In those patients in whom you are taking for a focused exploration under local anesthesia, what happens if you take the gland out and you don't get an adequate drop in your PTH?
So I would convert to general. But here's the thing. We're actually going to be presenting at the Academy a resident paper. I've stopped checking PTH on those patients where I clearly identify a single adenoma on my ultrasound, a good, thin neck, and I do it under MAC. We're going to present our data on that on like 160 patients.
So I will say that I do a fair bit of these cases under MAC, and I do bilateral explorations under MAC. I don't that to me is not, it doesn't, just because you have to do additional exploration doesn't, for me, it doesn't mean I automatically convert to general anesthesia. All right, so with that, let's just move on to Dave's case. I want to make sure we get to this because I think this is really kind of the other end of maybe the spectrum for minimally invasive disease, which is bilateral explorations with subtotal resection. So Dave, I know this case that you're going to present is the secondary hyperparathyroidism case. But I think a lot of the same principles apply whether you're dealing with secondary renal related disease or primary four-gland disease. So with that, would you like to do an introduction at all to the video, or do you want me just to play it and you'll introduce as you're going?
Yeah, let me just, so this is a 4D CT, and I find these incredibly helpful. So what we're looking at here on the left side of the screen is the non-contrast images. And on the right side of the screen are the arterial phase contrast images. And so now you can go ahead and play. So the nice thing about this is we can see all four parathyroid glands on this. And so I'll show those to you. So this is how I set it up. I'm looking at the non-con. You can see right there. Oh, there's a little glitchy, it looks like. But anyway, there is the superior parathyroid gland on the left. Marked by the marker.
Dave, just to clarify, sorry to interrupt. Do you do this scan in primary disease and secondary disease, correct?
I do. Yeah.
Yeah.
Obviously, you can't do it in someone that has renal insufficiency because of the contrast load. But
Yep.
this this allows you to see the superior parathyroid glands well, which I think can be challenging to see on ultrasound. That is the right inferior parathyroid gland. You can see on non-con it is hypodense compared to the thyroid, and then on arterial phase contrast, it avidly enhances. And so that's what these look like on 4D CT. And then we're going to see the left inferior one here in just a second. So this is, what's nice about this in this particular case is that seeing all 4 glands, I already have a pretty good sense as to how I'm going to address this surgically. So my right inferior gland is the largest gland. You can see that here on the ultrasound. It has this kind of bilobed appearance within the right lobe of the thyroid there. You can also look at your carotid artery and make sure that there's a subclavian takeoff, which tells you that, it's unlikely that there will be a non-recurrent laryngeal nerve. So that's what we're seeing there. And so then intraop, this is the superior parathyroid gland on the right. And I do not take down the superior pole of the thyroid. Typically, I just sort of use Dr. Terrace's retractor to sort of lift the lobe up. That's the right inferior parathyroid gland. That's the large bilobed one that's kind of stuck to the thyroid. And then here is the left inferior parathyroid gland that you can see right there. And then we'll show the left superior parathyroid gland, which is also what I thought was probably the smallest of the parathyroid glands on the imaging. And so this Terrace retractor kind of allows you to pull the thyroid up and elevate the superior pole and show the backside of the superior pole of the thyroid without having to release the superior pole vessels. And so there's the superior parathyroid gland on the left side. So when I'm doing a 3.5 gland removal, I always start with the gland I'm planning to save because it gives you a little bit of an insurance policy if you screw this part up. So I've taken half of that gland and I'm going to look at it to make sure that it is still vascularized, and you can see some bleeding coming from the stump away from the pedicle. The pedicle is coming from the medial side of the gland. And then I usually do mark this with a surgical clip. So you can see that right there. That way it can be identified again. And so once I'm happy with a vascularized gland, then it makes the rest of the case much less stressful because you've just got 3 glands to completely remove, knowing that you've saved at least part of one healthy parathyroid gland. So this is the removal of the left inferior parathyroid gland here. I like to just use bipolar for this, so I kind of do the cutting and the coagulating with the bipolar, and the goal being to try not to grab the parathyroid gland itself as you remove it, so you don't accidentally rupture it, as Maisie indicated earlier. So sometimes I'll leave a little bit of fat or fascia attached to it to allow you to kind of hold on to that with the pickups.
Dave, you might have said this, but I just wanted to clarify. So when you're doing this, and again, whether for renal or say for primary disease, and you think maybe there's 4-gland hyperplasia, multi-glandular disease, you find all 4 glands first, and then you do your subtotal, correct?
Correct. Yep.
Yeah.
I want to see all the glands and then decide which one I want to keep. So the 4D CT in this case was helpful. I kind of knew what I was going to do ahead of time, but I still want to see them all and identify them all, and really sort of tee them up on their pedicle before I do anything with any of them. And
so Dave, if you do, so you found now all 4 glands, and so you do a subtotal resection, you take out half, you take out a third, you take out however much of, say, that abnormal gland. You look at it, it's not vascularized. What do you do then?
Well, so then I've got thankfully 3 more glands that I can try that same thing on. And so yeah. I would go to the next best looking gland and try the same thing where I take half of it and make sure that I have a vascularized stump, which is why I start with the one that I'm hoping to keep.
Yep. I think that's like you explained that's a critical thing to get into a situation where you're down to that last thing, and now you've devascularized it, and you've got nothing left. I'm gonna ask this is a kind of a related question, and Dave Stewart already kind of talked about this, but in this situation where you've done a four-gland exploration and you're trying to differentiate, say, a subtle small adenoma, microadenoma, as Dave said before, from four-gland hyperplasia. Do Dave, Shanka, Dave Stewart, Maisie, do any of you have any hints, tricks that you use in those kind of difficult cases where you're trying to differentiate, really four-gland disease from a single nuanced, say, adenoma?
I think intra-op PTH is helpful in that situation. You can, if there's one gland that looks somewhat large, you can remove that and then see what happens to your PTH levels. So I think that's helpful. I have, using my my microvascular training, I have on occasion taken a small microvascular clamp, the reversible clamps, and actually clamped the pedicle to a suspicious parathyroid gland, and then drawn PTH levels. And the nice thing about that is if the PTH levels don't go down, you can take the clamp off, and you have not damaged the blood supply to the parathyroid gland. It's just the same vascular clamp that you put on an artery as you're getting ready to do microvascular anastomosis. So that's another option. Nate Boyd described that nicely in a paper many years ago now.
Dave or Maisie, do you have any comments on that?
Yeah, I think just one comment I'd make. I think David's point is if the PTH doesn't go down, you know that it's multi-gland disease. But the problem is once you've done the bilateral exploration, the corollary isn't necessarily true. And we all know you can do thyroid surgery, leave all four parathyroid glands, and the parathyroid level can be really low. Same thing can happen during parathyroid exploration. So I think it's hard. That's why I feel like once you've done that bilateral exploration, if you're not sure, you may be better err on the side of taking out multiple glands, which to me is 3 glands. Maybe I don't take 3.5 if I thought maybe it was really a little adenoma that the imaging didn't tell me, where it was initially. If you go first to the suspected small adenoma, then the PTH is really helpful. But if it's the last gland you find, or you're on the second side when you find it, I think you just have to understand that just because it went down after you took that out, you may have transiently devascularized some of those other glands.
Yeah, this is one of those challenges that I think that in the next few years, hopefully there'll be whatever emergence of one of these technologies that might be able to kind of further help us differentiate from normal from abnormal. So I see there's a question in the chat that I think is a fundamental question that's important to talk about, which is for these subtotal resections, how do you decide which gland to leave behind? And the question asks is, does location matter? So maybe you can talk, Dave, Shanka, about kind of deciding which gland. Again, this was a secondary case, which is maybe a slightly different, but certainly in a primary case. And if you have any nuances as it relates to renal cases, how do you make those decisions?
Yeah, so all other things being equal, I think my preference would be to leave an inferior gland, and that goes back to the reasons we discussed initially, which is that inferior glands are going to tend to be further away from the recurrent laryngeal nerve, less deep in the patient, more superficial, and therefore easier to get to in a reoperative situation. And so if all 4 glands are big, but they all look exactly the same, I'm going to try to leave an inferior gland. However, that's most of the time not the case, I would say. They usually look different, particularly in secondary cases. And I don't think you want to leave like a nodular enlarged gland behind just because you're trying to, save an inferior gland rather than a superior gland. And so in this video, that the right inferior and the left inferior parathyroid glands were the most abnormal. They were, the right inferior in particular was this big nodular gland that was stuck to the thyroid. So that's got to go. The superior glands were much more normal in appearance. And so even though we ended up saving a superior gland in that case, it was the healthier gland. And so I think that's the important thing, is to pick the gland that looks the most normal, smallest, flattest, least nodular appearing.
I think that's an excellent point. Dave or Maisie, we're kind of rounding out in terms of time. Do you have any additional comments to Dave's thoughts?
I would agree.
Very good.
I mean, the first rule of thumb is it going to be a viable gland you're going to be able to leave behind? And then if you have a choice of two, then pick the one that's going to be the least harm going back in. So, if it's like way down in the mediastinum, that might be hard to come back to. And you may want to take that out.
Yep. So I see that it is 8:01, and I really want to respect people's time. We had one other case that Dave Stewart was kind enough to share with us. Maybe we'll be able to get that information out in some other way. It's Dave, maybe you could just share the name of the retractor, because I think that's a valuable piece of information.
Sure. So Jamie Cohen, I don't know, 20 years ago, wrote a paper about using the Skyhook retractor, and I think it's more commonly known as the Rule, R-U-L-E track retractor, and it's used to harvest internal mammary arteries, I think, mediastinal stuff. It's got this big like chain crank that you crank up, and it'll pull the sternoclavicular joint anteriorly and really let you get into that anterior mediastinum. And there's the picture of it right there. You can just pause it right there. In this case, it helped us avoid a sternotomy in a third time re-op para, where unfortunately the prior surgeons had taken the other three glands, and this was the problem gland. But at least we didn't have to crack his chest to get there.
All right. So with that, I want to thank all the panelists, and I think that there was a lot of really cool tips brought up during this session. And I hope people learned something. I hope people enjoyed and can use some of these lessons to apply to your patient. And with that, I'm going to wrap up, and thank you everyone for joining us tonight.
Thanks for moderating.
Good night, everyone.
Good night.